Welcome to the second part of vasculitis. We have studied about the classification of vasculitis, and now we are going to look into the diagnosis and also the various classifications based on the size of the artery. It is a large, medium-sized, and the small-sized arteries, and the disease associated with these arteries. Now, on the diagnostic part, diagnosis of systemic vasculitis is actually a diagnosis or exclusion criteria are being used. So, like example for Church-Strauss type of vasculitis, the onset is adult onset asthma would be present for more than 2 years, followed by atypical pneumonia, and peripheral nerve involvement would be suggested. Also, apart from using the exclusion criteria, we should have certain fixed criteria for the establishment of a diagnosis. Also, biopsy is recurrently used to establish the type of vasculitis. So, the biopsy of the involved organ might be helpful in diagnosis. There are certain non-specific suggestive tests like ESR, CRP, that is C-reactive protein, erythrocyte sedimentation rate, computed tomography, CT would be helpful in cases of pulmonary hemorrhage and cavitary lesions. Bronchoscopy, urine analysis, ANCA analysis, that is anti-neutrophilic cytoplasmic antibodies, and angiogram, include both contrast angiogram and CT angiogram. So these are certain diagnostic tools that might be used. Now, as we have seen, the classification was based on the vessel size, that is large, medium, and small size vessels. The large vessels like aorta and its branches, medium, the main visceral artery, and the small size venule, capillaries, arterioles. This was a classification name, and we have a list of disorders associated with it. So what are these disorders, and we'll be looking into them one by one. And is starting from the giant cell arteritis, Takayasu arteritis, which is also known as the Bechet arteritis, polyarteritis nodosa, PAN, Kawasaki disease, and we also have ANCA associated small vessels arteritis, and also immune complex vasculitis. So, in relation to ANC, that is anti-neutrophilic cytoplasmic antibodies associated vasculitis, we have EGPA, that is eosinophilic granulomatosis with polyangiitis, which is also known as Church-Strauss syndrome, and granulomatosis with polyangiitis, that is Wegener's granulomatosis. We also have immune complex vasculitis, that is IgA vasculitis, Henoch-Schönlein purpura, that's the other name. So we'll have one by one an investigation into all of these. So for the start, starting up with the large vessel vasculitis, the very first one is the giant cell arteritis. So is the diagram is suggestive of it. So you can have a closer look where the arrow is marking. This is a disease of elder patients, the age of 50 and above 50. And it primarily affects the white people. And here, the ratio or the sex differentiation for the affection of the females would be affected more as compared to the males. And how is this presentation, the common presenting symptoms should be visible to us? That is fatigue, headache, and tenderness of the scalp, jaw and tongue claudication, temporal arteries are palpable, tender, and nodular. So, on examination, on palpation, we find that the temporal arteries are palpable, that is, they would be raised above the surface, they are tender to touch, and are nodular. We can feel with reduced pulsations. Visual disturbance, optic arteritis can lead to sudden and permanent blindness if present. If optic artery gets involved in it, so it can lead to blindness also. So these are certain characteristic features for giant cell arteritis. So it is affecting arteries supplying to the scalp or the optic region. Now you can on the left side you can see the arterial distribution starting from brachiocephalic artery and its division into subclavian artery and carotid artery, and that further dividing into various branches. So that one of them would get involved, it is the temporal artery would get involved in it. Even the optic artery might also get involved. Now the investigation, we have seen the briefing of the investigation, but still we find an ESR value which is raised above 100, and anemia and thrombocytosis may be associated. If we go for temporal artery biopsy, it's the definitive or the gold standard for establishing this type of arteritis. Aortic imaging may be considered, especially in patients with aortic regurgitation murmur. So, in giant cell arteritis, especially in patients with aortic murmur, imaging technique might be used, and the diagnosis is considered in any patient is confirmed by 50 years or more of the age with recent onset of headache, disturbance in vision, and myalgias with high ESR and C-reactive protein is the confirmation. So the confirmation for giant cell arteritis can be confirmed by presence of these symptoms. That is 50 years of age and more, headache, which is of recent origin. It should not trace back to the early life when the person was age of below 40 years of age. Disturbance of vision, myalgia, there is pain in various parts of the body, there is muscular pain. Also fever of unknown origin and high ESR, C-reactive protein and anemia. And we have PMR also, that is polymyalgia rheumatica. There's a characteristic of proximal muscle ages. As we have discussed, we have myalgia associated with giant cell arteritis. So it will have bilateral and symmetrical stiffness in various parts of the body. As both the side of the body will be involved, and the one which is getting affected on either side will have it synonymous with the other side also. The ESR is usually elevated, and some of these polymyalgia rheumatica patients may develop giant cell arteritis after few years, and 50% of patients with giant cell arteritis have symptoms of polymyalgia rheumatica. So there is a close association between both of these clinical conditions, where you can easily understand that as myalgia is a part of giant cell arteritis, so it becomes inevitable the person is suffering from polymyalgia rheumatica to develop giant cell arteritis. This was a classification chart, and the next arteritis in discussion would be Takayasu's arteritis. This type of arteritis, that is, it's a chronic inflammatory disorder. It is affecting aorta and its major branches. It affects women's mainly. There is the ratio to male and female. So from female to male is around 9:1. And it do affect females at a very early age of around 15 to 25. Unlike the giant cell arteritis, where the age affecting was more than 50 years. Now, the classification criteria, or how do we exclude or how do we diagnose it to be positive? The age of disease onset is obviously less than 40 years, and claudication of extremities is present. Uh, there is intermittent claudication where the person is not able to walk for a very long interval, or working with hands become difficult. If they have continuity of any sort of work, then the person has to pause to resume the work again. Decreased pulsation of one or both brachial arteries, difference of at least 10 milligram mm of Hg in systolic blood pressure between both the arms. So between the arms, if you examine one hand and the other, there would be a difference of at least 10 mm of Hg in the systolic pressure. Brute, it's a sound heard over the subclavian artery or the abdominal aorta, and arteriographic narrowing and occlusion of aorta in its large branches. So out of these six diseases diagnosed, if at least three of these six are positive in a person. So these are the definitive diagnostic characteristic. Age is more than less than 40. Intermittent claudication may be present, and decreased pulsation in one or both of the brachial arteries. Obviously, there is a difference in the systolic pressure in both the arms. Also, brute can be heard over the subclavian artery. These are the direct branches of aorta and abdominal aorta. When arteriographic narrowing may be seen. Now, coming to the investigation, high ESR in the early phases, followed by chest X-ray, which is widened aortic shadow, irregularity of descending aorta may be seen, cardiac enlargement, and hilar fullness. There is a lung region of lung showing fullness. PET scan may be also important. The PET scan is positron emission tomography, which is used uh, for detecting the extent of thickness in the wall of the aorta and monitoring the disease activity. If this PET scan is not available, arteriography will be helpful alternatively. This is how the X-ray might look like. You can see this X-ray, how it is looking like with these characteristic features. Again, you can see multiple focal stenosis in pulmonary artery branches. These are the stenosed area. You can see the narrowing occurring here. So this narrowing are actually not allowing the blood to flow further. And there is also an enlargement of the descending thoracic aorta and thickening of the vessel wall. So this was about Takayasu's arteritis. Now we'll come and shift on to medium-sized vessel diseases, in which the very first we have polyarteritis nodosa. Polyarteritis nodosa, PAN, it's a necrotizing inflammation of medium-sized small arteries causing segmental transmural inflammation of muscular arteries, but does not involve vein. So the characteristic feature is there is no involvement of vein. As in the earlier lecture, we have considered that there might be continuity between the small arteries and the vein, but here they are exclusive for this exclusive for the arteries, and they might be without A general necrosis or anti-neutrophilic cytoplasmic antibodies or vasculitis in arterioles, capillaries, or venules. For the first year, the etiology stays unknown, and in some cases, there would be an hepatitis B virus infection. Also, hepatitis C infection and hairy cell leukemia in the 2 years of development. Polyarteritis nodosa is twice commoner in males as compared to females around the age of 40. Its constitutional symptoms, or how does this particular disease manifest itself, is malaise, fever, weight loss, and musculoskeletal pain. So here also arthritic pains might be present. It might be involving both the joints and the muscles. How is the clinical manifestation? Kidneys are the most commonly involved organ, and as there is necrosis, so glomerular ischemia, not general necrosis, minimal proteinuria, modest hematuria, no blood cell cast indicative of general necrosis, and it serves as renin-angiotensin abnormality, renal impairment, and end-stage renal disease. Also, coronary arteritis with angina, there is pain in the chest region, and myocardial infarction, which is very uncommon to occur. Pericarditis is common, and which can lead to heart failure and ischemic cardiomyopathies or severe hypertension might be the resultant of such type of disease, that is PAN or the arthritis nodosa. On GIT, abdominal pain, bleeding, and bowel obstruction or perforation may be present. Rupture of mesenteric aneurysm. There might be a rupture of mesenteric aneurysm, and interperitoneal hemorrhage may be seen. Asymmetric polyneuropathy. There is arteritis of vasa neurosa, painful mononeuritis multiplex, vasculitis of CNS if it's affecting the CNS, encephalopathy, convulsions may be present along with this. So how does it looks like? This is the gangrenous state and other skin lesions that becomes visible. Cutaneous lesions, vascular purpura, libido reticularis, peripheral gangrene, and painful skin nodules may be seen. Myalgia, there is pain in the muscles, and also arthralgia, there is pain also might be seen in the joints. Orchitis and epididymitis may also be present. So this is how the clinical manifestation looks like. So it's affecting various parts of the body. It depends on which artery is getting involved, in which part of the artery or supplying which organ gets involved. Now about its investigation, ESR, CRP, these usually are high. WBC and thrombocytosis may be seen. Anemia, hematuria, and mild proteinuria if it's affecting the arteries of kidney. Hypocomplementemia, ANCA is negative. It's not involving anti-neutrophilic antibodies. Hepatitis B surface antigen might be seen as it might be an affection added to it. Angiography often shows microaneurysm and stenosis, and biopsy is the confirmatory test, as we discussed earlier, that biopsy would be the definitive diagnosis. We'll continue with Kawasaki disease and diseases of small vessels in the third part of vasculitis.